Head-to-toe physical examination in CTD patients. 1. General examination. This first look provides vital clues about the severity and chronicity of the illness. Vitals. Why? They reflect systemic inflammation and acute, life-threatening complications. A fever suggests an active inflammatory process typical of a lupus flare. Tachycardia, rapid heart rate, can result from fever, anemia, or direct cardiac inflammation, myocarditis. A sudden, severe rise in blood pressure in a patient with scleroderma is a medical emergency, signaling a potential scleroderma renal crisis. Appearance and general signs. Why? These signs paint a picture of the overall burden of chronic disease. Cachexia, muscle and weight loss, and profound fatigue point to a high inflammatory load. Pallor, paleness, can indicate anemia of chronic disease, or, more acutely, hemolytic anemia, immune destruction of red blood cells, which is common in systemic lupus erythematosus, SLE. Finger clubbing is a classic sign of underlying interstitial lung disease, ILD, a serious complication seen in scleroderma and myositis. 2. Skin and mucosa. The skin is a window to rheumatic disease, as many findings are highly specific. Rashes. Why? The rash's appearance and location are powerful diagnostic clues. The malar butterfly, rash across the cheeks and nose that characteristically spares the nasolabial folds, is a hallmark of SLE. A heliotrope rash, a purplish hue on the eyelids, combined with Gottron's papules, raised, scaly red patches over the knuckles, is pathognomonic for dermatomyositis, pointing to inflammation of both skin and muscle. Skin texture and lesions. Why? Changes in skin texture often reveal the core pathology of fibrosis or vascular damage. Sclerodactyly, thickened, tight, shiny skin on the fingers, is the cardinal sign of systemic sclerosis, scleroderma, caused by excessive collagen deposition. Telangiectasias, dilated small blood vessels, and calcinosis cutis, calcium deposits under the skin, are features of the limited form of scleroderma, formerly Crest syndrome. Livedoreticularis, a lace-like purplish pattern on the skin, suggests sluggish blood flow and can be a sign of antiphospholipid syndrome, APS. Mucosal and hair changes. Why? The immune system also targets mucosal surfaces and hair follicles. Painless oral or nasal ulcers are a key diagnostic criterion for SLE. Diffuse, non-scarring alopecia, hair loss is also characteristic of active lupus. Musculoskeletal system. This system is almost always involved in CTDs. The goal is to identify inflammatory disease. Joint examination. Why? To find evidence of active synovitis, inflammatory arthritis. Swelling, warmth, and tenderness are the classic signs. While this is the hallmark of rheumatoid arthritis, a similar, though typically non-erosive arthritis is common in SLE. Jacquard's arthropathy, a deforming but non-erosive condition caused by ligament laxity, can also be seen in lupus. Muscle examination. Why? To detect myositis, muscle inflammation. The key finding in polymyositis and dermatomyositis is symmetrical proximal muscle weakness. Patients will have difficulty raising their arms to comb their hair or standing up from a seated position without using their arms for support. 4. Vascular examination. Damage to blood vessels, from tiny capillaries to larger arteries, is central to many CTDs. Raynaud's phenomenon. Why? This is often one of the very first signs of a CTD, especially scleroderma. It is a distinct, triphasic color change in the fingers in response to cold or stress. White, from vasospasm cutting off blood flow, then blue as tissues lose oxygen, and finally red as blood flow returns. Nail fold capillaroscopy. Why? This simple bedside exam provides a direct look at microvascular health. By examining the capillaries at the base of the fingernail with a magnifier, dermatoscope, a clinician can see specific changes. In scleroderma and dermatomyositis, the normal fine capillary loops become distorted, enlarged, giant capillaries, and eventually disappear, drop out. This finding is highly specific. 5. Respiratory system lung involvement is a leading cause of serious illness and death in CTDs. Auscultation, listening to the lungs. Why? To detect signs of fibrosis, scarring, or pleuritis, inflammation of the lung lining. Fine, dry, Velcro-like crackles heard at the end of inspiration, especially at the lung bases, are the classic sign of interstitial lung disease, ILD. This is a major complication in systemic sclerosis, myositis, and RA. A pleural friction rub, a leathery grating sound, indicates pleuritis, common in SLE. 6. Cardiovascular system. The heart and its surrounding structures are frequent targets of systemic inflammation. Auscultation, listening to the heart. Why? To identify inflammation of the heart or signs of pulmonary hypertension, a scratchy pericardial friction rub points to pericarditis, inflammation of the sac around the heart, a classic feature of SLE. A loud P2, the second heart sound is abnormally loud, is a key sign of pulmonary hypertension, a dangerous rise in blood pressure in the lungs that is a major complication of systemic sclerosis. 7. Abdomen. Though less common, involvement here can be severe. Abdomen. Why? To check for organ enlargement from immune system hyperactivity, hepatosplenomegaly, enlarged liver and spleen, can be found in active SLE or Sjogren's syndrome, as these are organs of the reticuloendothelial system. 8. Nervous system. Why? The immune system can attack the brain, spinal cord, or peripheral nerves directly or by inflaming their blood supply, vasculitis. This can cause a vast range of symptoms, from cognitive issues, lupus fog, and psychosis in neuropsychiatric SLE to numbness and weakness from peripheral neuropathy in vasculitis. 9. Eye and oral examination. This is essential for diagnosing Sjogren's syndrome. Dryness and gland swelling. Why? This is the hallmark of Sjogren's syndrome, where the immune system attacks and destroys moisture-producing glands. Patients report intensely dry eyes, keratoconjunctivitis sicca, and a dry mouth, xerostomia. A Schirmer's test can quantify tear production. Examination may also reveal firm, bilateral swelling of the parotid glands, the main salivary gland,